Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 113 of our pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. And our first question reads, Mrs. STK, a 25-year-old female patient in her second trimester of pregnancy, presents to your antenatal clinic and is diagnosed with neurosyphilis. She is allergic to penicillins, and you establish she had anaphylaxis at the age 13 years ago, to be specific. So my question to you is, which of the medications listed below would be the most appropriate treatment option for Mrs. STK? Would you choose to treat her with doxycycline, ceftriaxone, penicillin with desensitization, or azithromycin? I'll give you 10 seconds to choose the correct answer. I would choose to treat this patient with penicillin with desensitization. Now, penicillin with desensitization should be used in pregnant patients with neurosyphilis. Remember, doxycycline should not be used during pregnancy and is considered contraindicated in this cohort of patients. And then ceftriaxone has insufficient data in pregnancy to be recommended for prevention of congenital syphilis. Let's move to the next question, please. And the next question reads, which of the statements listed below best describes how to obtain blood cultures for the diagnosis of endocarditis? Is it A, at least 5 sets of blood cultures with the first and last being drawn at least 1 hour apart? Or is it B, at least 4 sets of blood cultures with the first and last being drawn at least 1 hour apart? Or is it C, at least 3 sets of blood cultures with the first and last being drawn at least 1 hour apart? Or is it D, at least 2 sets of blood cultures drawn at least 1 hour apart? I'll give you 10 seconds to choose the correct answer. C is the correct answer. At least 3 sets of blood cultures with the first and last drawn at least 1 hour apart. According to the AHA/IDSA guidelines, at least 3 sets of blood cultures should be obtained from different venipuncture sites within the first and last samples being drawn at least 1 hour apart. Let's move to the next question, please. And it reads, Mrs. DMA, a 69-year-old female patient, was admitted to your medical ICU and is now on ventilator support. She has a past medical history of hyperlipidemia, hypertension, and type 2 diabetes mellitus. 60 days ago, she received an IV course of vancomycin and piperacillin tazobactam for 14 days for a diabetic foot infection. The chest X-ray is consistent with pneumonia on day 10 of admission. Now, the infectious diseases team at your hospital decides to initiate empiric therapy with IV linezolid. So my question to you is, which of the regimens listed below would be appropriate for gram-negative bacteria coverage in Mrs. DMA's case? Would you settle for ticagrelin flavulanates plus colistin, or would you combine doripenem and amikacin, or would you settle for ceftazidime and ciprofloxacin, or would you opt for ceftriaxone and levofloxacin? I'll give you 10 seconds to choose the correct answer. I would treat this lady with ceftazidime and ciprofloxacin, both via the IV route. Now, the IDSA VAP/HAP guidelines recommend the combination of an anti-pseudomonas beta-lactam and an anti-pseudomonas non-beta-lactam in the treatment of this cohort of patients. Now, ceftriaxone doesn't have clinically meaningful coverage for Pseudomonas aeruginosa, so that makes D very wrong. Then I would like to add that doripenem in answer B had inferior outcomes to standard therapy for non-fermenting gram-negative pathogens such as Pseudomonas in a HAP study, which is reported somewhere in literature. Then ticagrelin clavulanate used to be an option in HAP or VAP guidelines, but has disappeared in the era of evidence-based medicine. It's no longer popular. Now, while an anti-pseudomonas aminoglycoside or a fluoroquinolone is preferred, polymyxin can be used in hospital units with high rates of multi-drug resistance. Now, just like to remind you that total body weight should be used to dose vancomycin according to the vancomycin consensus statement, just for purposes of safety. Then I would like to remind you that linezolid and vancomycin have been shown to have similar rates of thrombocytopenia when they are used for equal to or 2 weeks. Equal to or less than 2 weeks. Now, beyond the 2 weeks, linezolid causes more thrombocytopenia. Now, I would like to remind you that telavancin has an increased risk of mortality in patients with HAP who have had creatinine clearance values of below 50. So be very careful when considering its use in this cohort of patients. Let's move to the next question, please. The next question reads, Master TMC, an 8-year-old boy is brought to your urgent care clinic by the mother. The pediatrician on duty highly suspects a case of group A streptococcal pharyngitis, which we abbreviate as GAS pharyngitis. They plan to travel out of the country for vacation, and the mother requests for a therapeutic option with the shortest duration possible. They do not want to miss their flights. Time is running out for them. This kid has no known drug or food allergies and is not taking any medication currently. So my question to you is, which of the medications listed below would be suitable as a single dose regimen for Master TMC? Would it be ceftriaxone, dalbavancin, benzathine penicillin G, or would you settle for azithromycin? I'll give you 10 seconds to choose the correct answer. I would choose to treat this young man with benzathine penicillin G. The IDSA Group A streptococcal pharyngitis guidelines recommend benzathine penicillin G as the only single dose treatment option. I would like to add that azithromycin can be used as a 5-day course, but 10-day courses of clarithromycin may be more effective. I would also like to add that ceftriaxone should be avoided in patients with GAS pharyngitis due to its increased cost, for example, and even the excessively broad spectrum of activity, which would have a downside. It would select for antibiotic-resistant flora in the gut or in the body. Then I would like to add that delbavancin hasn't been evaluated in clinical trials against GAS pharyngitis, and it has an excessively broad antimicrobial spectrum and is much more costly than penicillin. I would like to add that azithromycin is administered at the same dose for all the 5 days. If you opt for it, it would be prudent to dose it at 12 milligrams per kilo per day as a single dose, and up to a maximum of 500 milligrams if the body weight of the baby is high. I'd like to remind you that benzathine penicillin G is the only IM option recommended for GAS pharyngitis according to the IDSA guidelines. Let's move to the next question, please. And the next question reads, Mrs. DFT, a 35-year-old female, presents to your hospital with a herpes zoster infection. She has no known drug or food allergies and is currently taking no other medication. She has a serum creatinine of 0.8 milligrams per deciliter. So my question to you is, which of the acyclovir regimens listed below would be the most appropriate for Mrs. DFT? Would you settle for 800 milligrams orally thrice a day? Or would you settle for 400 milligrams orally thrice a day? Or would you administer 800 milligrams every 5 hours? Or would you settle for 400 milligrams administered orally every 5 hours? I'll give you 10 seconds to choose the correct answer. I would recommend 800 milligrams every 5 hours orally. Now, acyclovir requires 5 times per day dosing, and that should be at a dose of 800 milligrams to be effective for herpes zoster. I would just like to add that valacyclovir and famciclovir can be dosed thrice daily, partly due to the improved bioavailabilities as compared to acyclovir. So those frequencies in A and B apply to valacyclovir and famciclovir. Let's move to the next question, please. And it reads, which of the integrase inhibitors listed below is or are preferred in pregnancy? Is it bictegravir, dolutegravir, elvitegravir, or is it raltegravir? I'll give you 10 seconds to choose the correct answer or answers. Both raltegravir and dolutegravir are correct answers. I would like to remind you that raltegravir is listed as a preferred integrase inhibitor by the DHHS guidelines, and dolutegravir was recently listed as a preferred integrase inhibitor by the DHHS guidelines, although it carries a risk of neurotube defects. Now, there is insufficient data for the use of bictegravir in pregnancy. And guidelines recommend against the use of Elvitegravir containing regimens in pregnant women, as inadequate drug concentrations and viral breakthrough have been reported during its use in pregnant women. So avoid Bictegravir and Elvitegravir, and you can comfortably use either Dolutegravir or Raltegravir. Let's move to the next question, please. And it reads, J and V, a 2-week-old female patient, is rushed to your pediatric accident and emergency department after developing meningitis. She has no known past medical history, and the neonatology resident on duty consults you as a clinical pharmacist specialist in infectious diseases as on the most appropriate regimen for baby J and V. So my question to you is, which of the regimens listed below would you regard as the most appropriate for baby J and V? Would you opt for ceftriaxone plus gentamicin? Would you settle for cefotaxime plus gentamicin? Would you settle for ampicillin, cefotaxime, and gentamicin? Or would you settle for ampicillin, ceftriaxone, and gentamicin? I'll give you 10 seconds to choose the correct answer. I would settle for ampicillin, cefotaxime, and gentamicin. Now, ampicillin and gentamicin should be part of the empiric regimen, since patients in this age bracket are at a risk of meningitis due to Listeria monocytogenes. Now, ceftriaxone, on the other hand, is contraindicated in neonates of this age because of the risk of hyperbilirubinemia and kernicterus that could result if we used it. Let's move to the next question, please. And it reads, FTP, an 11-month-old boy, is brought to your pediatric clinic by his parents with a chief complaint of bark-like cough, loud breathing, and is more fussy than they usually observe on a daily basis. The parents deny any vomiting or fever, and this boy has some mild stridor sounds on the lung examination, accompanied by nasal flaring. So my question to you is, which of the microbes listed below would be the most likely cause of baby FTP's clinical picture in this clinic visit? Would it be Corynebacterium diphtheria? Would it be human parainfluenza type 1? Would it be group A beta hemolytic streptococcus? Or would it be Haemophilus influenza type B? I'll give you 10 seconds to choose the correct answer. So human parainfluenza type 1 it is. Now this is a classic case of croup which affects children most commonly 6 months to 3 years of age and is most commonly caused by human parainfluenza types 1, 2, or 3. Now the parents talked of a bark-like cough, there was loud breathing which led to stridor, and this is usually caused by the subglottic narrowing and edema from the viral infection. And I would like to remind you that since croup is caused by viral infection, antibiotics wouldn't be useful or helpful in such a patient. Actually, the treatment of choice would be dexamethasone. You can do 0.5 milligrams per kilo orally once, or there are clinicians who do 0.3 or even 0.6 milligrams per kilo as start oral doses. Now, historically, clinicians have used the 0.6 milligram per kilo dose, but smaller doses have been shown to be effective. I'd just like to add that bacterial tracheitis, which is also called laryngotracheobronchitis, a very long word indeed, is most commonly caused by Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Now, epiglottitis is most commonly caused by Haemophilus influenza, but can also be caused by human parainfluenza types 1, 2, and 3. I would just like to add that a soft tissue AP radiographic view classically demonstrates a stipple sign due to the subglottic narrowing caused by the viral infection. So that's a characteristic feature that you can use to quickly diagnose group in this cohort of patients. Let's move to the next question, please. And it reads, Mrs. SJM, a 37-year-old female patient, presents to your accident and emergency department with a past medical history of POS, polycystic ovarian syndrome. Her chief complaint today is purulent nasal discharge. She has some facial pain. And her viral pharyngitis has lasted slightly less than 7 days. And you are told initially it was improving, but has since suddenly worsened with symptoms including headache and increased nasal discharge for the past 4 days. So this is what we call double sickening. Temperature is 100.5 degrees Fahrenheit. She's allergic to penicillins, and she tells the clinician she couldn't breathe after taking amoxicillin 20 years ago. So my question to you is, which of the therapeutic options listed below would you consider to be the most appropriate for Mrs. SJM? Would you consider cotrimoxazole the most appropriate, or would it be doxycycline, or would it be cefixime, or do you think it would be erythromycin? I'll give you 10 seconds to choose the correct answer. I would settle for doxycycline. Now, the IDSA guidelines for acute bacterial sinusitis state that doxycycline or respiratory fluoroquinolones should be used for adults who are allergic to penicillin, or if they are female of childbearing age, and such patients must be non-pregnant. I would just like to emphasize that third-generation cephalosporins such as cefixime should be avoided due to the variable rates of Streptococcus pneumonia resistance, and they are only recommended for children with penicillin allergies, but they should be used in combination with clindamycin. I would just like to add that macrolides such as erythromycin, clarithromycin, and azithromycin and cotrimoxazole should be avoided due to the high Streptococcus pneumonia resistant rates, which are almost 30 or even above 30%. In addition, 30 to 40% of Haemophilus influenza isolates are resistant to cotrimoxazole. So A would not be a suitable answer. C and D would also not be suitable. Remember, erythromycin should be avoided for most cases due to its frequent dosing. Remember, it's QID. There are also higher rates of GI adverse effects and even drug-drug interactions because it's a very potent CYP3A4 inhibitor. So just like to add that doxycycline should be avoided in children, especially those below the age of 8, due to the fact that it can bind to teeth and to bones and adversely affect childhood development. Let's move to the next question, please. And the next question reads, Mrs. MDM, a 79-year-old female patient, presents to your accident and emergency department with severe diabetic foot infection. She is allergic to clarithromycin, and the last time she took it, she had nausea, vomiting, and diarrhea. Currently, she administers insulin 70/30 and takes aspirin, simvastatin, and ramipril as an outpatient. So my question to you is, which of the agents listed below would be the most appropriate for Madam MDM in this clinical scenario? Would it be timentin, that is ticagrelin, clavulanate, or would it be unacin, ampicillin, sulbactam, or would it be tazocin, piperacillin, tazobactam, or would you settle for augmentin, amoxicillin, clavulanate? I'll give you 10 seconds to choose the correct answer. I would treat this patient with piperacillin tazobactam. Remember, zocin or piperacillin tazobactam is the only beta-lactamase inhibitor combination recommended for severe diabetic mellitus foot infections according to the IDSA guidelines. Now, unacin, that is ampicillin sulbactam, or timentin, ticagrelin, clavulanate, are only recommended for moderate infections. Then augmentin, that is amoxicillin, clavulanate, is recommended for very mild cases. All those many words justify why C, zocin or piperacillin tazobactam would be the best choice. Let's move to the next question, please. And it reads, Mr. HGT, a 45-year-old male patient, presents to your accident and emergency department with community-acquired pneumonia, CAP. He has a past medical history of fibromyalgia, chronic fatigue syndrome, and AFib. An X-ray is done, and it shows multilobar infiltrates, and the lab works show WBC of 18,000 cells per mm cubed, a platelet count of 90,000 cells per mm cubed. He has a BUN of 24 and a serum creatinine of 1.2. So my question to you is, what level of care would be the most appropriate for Mr. HGT? Now, where would you admit him? Would you send him to an internal medicine ward? Would you admit him to the medical ICU? Would you admit him to a 23-hour observational stay? Or would you try this patient and discharge him home with oral antibiotics? I'll give you 10 seconds to choose the correct answer. So I would choose to admit this patient in the medical ICU. Remember, the IDSA guidelines recommend that anyone presenting with 3 minor criteria be admitted directly to the ICU or a high-level monitoring unit such as the HDU. Now, patient HGT has a BUN that meets the criteria of equal to or above 20 milligrams per deciliter. Also meets the criteria of platelet counts being equal to or less than 90,000 cells per mm cubed. And it's also reported he has multilobar infiltrates on the X-ray. Let's move to the next question, please. And the next question reads, Mr. BJM, a 66-year-old man, was admitted to a general medical ward 3 weeks ago. He has no known drug or food allergies. Currently, he takes amiodarone, aspirin, amlodipine, lisinopril, carvedilol, and he administers both NPH insulin and regular insulin. He also takes warfarin, and he's on day 17 of IV ceftazidime for osteomyelitis due to Pseudomonas aeruginosa. His blood culture returns positive for Candida parapsilosis. So my question to you is, which of the following would be the most appropriate antifungal therapy for Mr. BJM now? Would you opt to treat him with voriconazole, micafungin, amphotericin B lipid complex, or fluconazole? I'll give you 10 seconds to choose the correct answer. I would treat this fellow with amphotericin B lipid complex infused over 4 hours once daily. Remember, fluconazole or the lipid formulations of amphotericin B are favored over echinocandins for the treatment of Candida parapsilosis. That disqualifies alternative B. Now, this is due to the fact that echinocandins have higher MIC values and lower clinical success rates against Candida parapsilosis. I would like to emphasize that fluconazole is favored over amphotericin B lipid formulations due to a better safety profile for most patients. However, Mr. BJM is receiving amiodarone, which precludes the use of an azole antifungal because of the increased risk of QTc interval prolongation. There would be a risk of a terrible arrhythmia. So despite being a very good choice, I would not opt for those two azoles, voriconazole and fluconazole. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to please give it a thumbs up, to like it, to share it widely with your peers, and to leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you that the very, very best is yet to come. And I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and very kind collaboration, and I look forward to interacting with you in the next video. Thank you.